is defined as a disturbance in the normal transmission of impulses generated in SA node. The normal PR interval is 0.12 second. When it exceeds 0.2 seconds, then this condition is called as heart block. Some of the causes for heart block are myocardial infarction, inflammation of the myocardium or the conducting system, and excessive vagal stimulation. There are different types of sinoatrial nodal block. Here the level of block is within substance of SA node. After an interval of approximately 2 cardiac cycles, the heart resumes its normal action as some new pacemaker other than SA node takes over. The impulse originates spontaneously in the AV node. The rate of QRS T complex is altered. AV nodal block. Here there is a disturbance of conduction between atria and ventricles. There are two types of AV nodal block: incomplete heart block and complete heart block. So this diagram showing normal cardiogram, and this is showing a SA node block. And when SA node block is there, so then the autorhythmic activity taken by the AV node, and this is the complex which is produced by the AV node. Incomplete heart block are of two types, that is first degree heart block and second degree heart block. In first degree heart block, the PR interval is prolonged, that is about 0.2 seconds, but all atrial impulses reach ventricle. All P waves are followed by QRS complex. In second degree heart block, here is also there is a prolonged PR interval above 0.2 second, but all atrial impulses are not conducted to ventricles. All QRS complexes are preceded by P waves, but all the P waves are not followed by QRS complexes. And it is of two types, that is 2:1 heart block. Here every 2 P waves are followed by a QRS complex. In 3:1 heart block, here every 3 P waves is followed by a QRS complex. And Wenckebach phenomena is in this condition, PR interval is prolonged progressively until one impulse fails to be transmitted to the ventricles, and it is a cyclical phenomena. Complete heart block is here there is no impulse is transmitted from atria to ventricles. There is a complete atrioventricular dissociation. Atria contracts at its own rate and ventricle contract independently at its own rate and rhythm. So that is why it is called as idioventricular rhythm. When complete heart blocks occurs suddenly, the ventricles take some time before it can beat as its own rhythm. During this time, there is a cerebral anoxia as there is no cardiac output. This will lead to syncope and fainting attack called Stokes-Adams syndrome. So this is a diagram showing the normal rhythm. So this showing the first heart block where there is a prolonged PR interval, and here it is showing different types of second degree heart blocks, that is Wenckebach phenomena. Here PR is prolonged at subsequent beats, and at one point the QRS complex disappears. And incomplete heart block, there are 2:1 block. After 2 P waves, there is a appearance of ventricular complex. In 3:1 block, after 3 P waves, there is appearance of 1 QRS complex. And third degree heart block is total AV dissociation, that is there is no relation between atria and ventricular contractions. Bundle branch block. Here there is a block of one of the branches of bundle of His. So excitation process passes normally down to the bundle on the intact side and then sweeps back through the muscles to activate the ventricles on the blocked side. It may be right bundle branch block, left bundle branch block, and hemiblock, that is fascicular block. When block occurs in the anterior or posterior fascicles of the left bundle branch, it produces hemiblock. Here you can see this is a normal complex, and in left bundle branch block, we can see the M pattern, the QRS complex is seen, and in WB, that is in right bundle branch block, you can see the W pattern in the ventricular complex in lead 1. So this is seen in lead 1 and this is seen in V6. WPW syndrome, that is Wolff-Parkinson's-White syndrome, a congenital abnormality where an accessory bundle of muscle fiber is called bundle of Kent connects right atria to the ventricles. As a result, depolarization wave from the atria is transmitted to ventricle faster bypassing the AV node. So AV nodal delay is absent and PR interval is shortened. Here, wide slurred QRS complex is obtained. Normally, beat conducts down the AV node, but here impulse is transmitted retrograde to the atrium due to the aberrant bundle. A circus movement is thus established. So here you can see because of the bundle of Kent, the recircus movement, circular movement is established in WPW syndrome, where it is characterized by wide and slurred QRS complex. Long-Ganong-Levine syndrome. Here depolarization passes from atria to the ventricles via aberrant bundle. The impulses between bypasses AV node but enters interventricular conducting system distal to the node. QRS complex is normal but PR interval is shortened here. In myocardial infarction,